So maybe we're going to start right now. So the configuration today is you have just implanted a patient with sinus dysfunction, and you have implanted a dual chamber Medtronic device. So you are inside the implanting room, and then you need to program the device. So the first thing, once you have implanted the device, every time we need to check, you see what you see here in green, this line about the remaining longevity. When you implant a device, it's supposed to be new and it's supposed to work properly, but it's not frequent, but you need to check that this line is green. Sometimes it is gray, and it can happen when the device has remained, for example, in the trunk of the car of the Medtronic rep. And sometimes when it's full or something like that, you can have a deterioration of the device, and then you will be in gray here. So the first thing I ask every time to the nurse who is with me during implantation is to check that this is green and that, of course, the device will work properly and is not old, for sure. That's the first point. The second point here, we go inside patient here. We're going to click there. And I ask the nurse to enter the information. You need to have the name, for example, of the patient. That's trivial, but if you want to follow a patient with remote monitoring, if you do not write the name right here, then you will not have the name on the site for remote monitoring. You always will have the number of the device, but if you want to know the name of the patient, and I think it can be important for the follow-up, you need to enter the name here for remote monitoring. And I think also every time I ask that, you enter which kind of lead is it? Is this unipolar or bipolar? And sometimes also you see the notes. If there is something very specific in this patient, I ask the nurse to write it right there. And then every time I will interrogate the device, I will know that this patient, for example, received anticoagulation for atrial fibrillation, something I consider clinically relevant or relevant in terms of the device, if there is a lead dysfunction or something like that. Okay, so now if you come back to the screen, so that's a specificity of Medtronic, but some of the physicians will not interrogate immediately the device at the time of implantation. So here you see that it's written implant detection in progress. Can you show us where? Yeah, you see here, it's written implant protection in progress. It means that once you have connected the lead to the device and place the pacemaker inside the pockets, then we'll start a duration of 30 minutes. And during 30 minutes, there are going to be a few tests that are performed. So usually when I implant the device, I will immediately interrogate and program the device. In some centers, what is done is that the device is implanted, and then the device is only interrogated the day after the implantation, not inside the EP lab. What you need to know is that you let it like this, implant in progress during 30 minutes. If you go on in parameters, nominally, that's the nominal programming here. It is programmed on AAI DDD. So this is now the nominal programming for a dual chamber pacemaker. But what you need to know is that during the 30 minutes, the device will work in DDD mode, not in AAI DDD. So during 30 minutes, it will perform some tests to verify the polarity of the leads. You see here, pace polarity is configured, sense polarity is also configured. It means that you do not, at this time, you have not entered the information and said, you have not programmed the fact that this lead is, for example, unipolar or bipolar. So the device does not know if it is a unipolar or bipolar lead. So during 30 minutes, it will repeat some tests to be sure that this is really a bipolar lead, for example. So once you connect it, it will work in DDD mode for 30 minutes. After 5 minutes, it will increase the rate of pacing, and it will try to pace bipolar. And if the value of impedance in bipolar pacing will remain in bipolar pacing, both for the atrium and for the right ventricular lead. After 30 minutes, he will repeat this test and will perform measurements of impedance in bipolar pacing. And if it works properly, it will then remain in bipolar. So either you interrogate the device and program it, and there's no problem. But if you do not interrogate and program, that's how it will work for the next 30 minutes. Do not be surprised if you connect the leads and it does not work in AAI DDD, but in DDD for 30 minutes. Okay. Any question about that? Okay. Then now you have implanted this device in a patient with sinus node dysfunction. So we're going to discuss on which parameters I think you should program and how you should program it and how the different algorithm will work. The first very important point, of course, is the mode. So if you click on the mode, you see now that nominally, the nominal programming is AAI DDD. Okay, AAI DDD, it's not, no, come back, AAI DDD. It's not, no, do not change, please. So AAI DDD, that's a nominal programming. You know that in this patient with sinus node dysfunction, the aim, of course, will be to pace the atrium if required, and if you can, to avoid as much as possible avoidable right ventricular pacing. You know, if you have a spontaneous conduction between the atria and the ventricle, the one thing very important when you will try to program the device is to decrease as much as possible the amount of right ventricular pacing. And that's a specificity if you compare the different companies, Abbott with Medtronic, with Boston. Most of the modes are common, of course, for all the devices, but there is a specificity, and this is this mode. So AAI DDD, the marketing name for Medtronic is MVP, Managed Ventricular Pacing. The point here is not to pace the ventricle if you only have sinus dysfunction with normal atrioventricular conduction, but you need to pace quite immediately if happens a problem of AV block. And what is very important to know for Medtronic device is that there are two versions of the MVP, of the AAI DDD, the old one and the new one that you can find in the new devices. But sometimes you will interrogate it, all devices implanted, I don't know, between 5 to 10 years before. And then in these devices, the MVP will work with the old versions. So if you stop now your screen, I will share mine. Okay, question. So I think you will have the response. Which company is this? Which device? It's a dual chamber pacemaker. And then you have implanted the device, and then you see this on the ECG. First of all, you need to know that sometimes you can be called by the nurse because of something, a device does not function correctly, and you need to know the specificity of the different companies. So according to you, which kind of device is this? Is this Medtronic, Abbott, Biotronic? Someone has an ID?
I guess it's a Medtronic.
I think you're right. Why?
Because this trace shows the MVP algorithm and how it works.
Yes.
Actually, trying to letting the own patient's rhythm go after the atrial stimulation.
So here you're functioning in DDD, agree? Pacing the atrium, pacing the right ventricle. And then what happens here?
It tries to, is looking for a spontaneous ventricular rhythm.
Yep. So you pace the atrium with a capture here.
Yes, it captures the atrium, but then there is an AV block. There's no transmission.
No R wave. Okay.
No R wave. And after that, since the atrial rhythm is, since there is no spontaneous rhythm from the atria, captures it launches a stimulation in the atria, and then rapid stimulation of the ventricle.
Okay, so how is the AV interval here? How much? The duration of the AV interval, do you know?
80 milliseconds.
It is 80 milliseconds. So if I understand, paced atrial, blocked, then you pace the atrium, and then you will pace, with backup pacing with 80 milliseconds. Okay? Okay.
Yes.
Then
it is still looking for a spontaneous AV conduction.
Yep.
Since only one blocked conduction is not sufficient to reverse to DDD, so it does
switch to DDD. Yeah.
So it does the same thing, where it just stimulates the atria and then launches a ventricular stimulation 80 milliseconds after.
Yep.
And since 2 of the 4 last beats are not conducted to the ventricle, it switches back to DDD.
Okay, so that's clear for everybody. If I show you this like this, up, just okay. So if this is a new or old Medtronic device, according to you? That's the old versions of the MVP. So it was very simple. With this kind of version, you could have blocked P wave. That's the first point. So for example, this is not a dysfunction. This is how works the algorithm. And as I say before, sometimes the nurse will call you and say, okay, I think your device you have just implanted is not working properly because there are some blocked P wave. But that's the way it is working normally. That's the normal functioning of this algorithm. So you see here, one block atrial activation, then you pace 80 milliseconds after the next atrial pacing. It is not enough to reverse and to switch to DDD. But then the next one is also blocked. So if you count the P waves or the atrial activation, this one is blocked, this one is not blocked, this one is blocked. So it's 2 out of 4. So you repeat 80 milliseconds and you switch back to DDD. Okay, that was very simple. The functioning of the MVP, the old one, was very simple. One of the limitations was that you could have some ventricular pause. You see, more or less double to the minimal heart rate. If you are programmed to 60 beats per minute, you could have ventricular pause of around 2 seconds. And I will show you on a tracing that can be a problem. And there was no question about the PR interval. If you look at this tracing, for example, this one, you see here that that's a patient with an old Medtronic devices working in MVP. You see here there is a long PR interval. So you pace the atrium, and then the interval with the next R wave is around 350 milliseconds. But with this kind of algorithm, so with the old Medtronic devices, you could not switch to DDD when a patient encountered a problem of long PR interval. The only criterion for switching from AAI to DDD were 2 blocked P waves out of 4, one single parameter. And that could be sometimes a problem. You are still there? Yes?
Yes.
What do you think about this tracing? That's now a patient with an ICD, but the device is also working with the MVP. What happens here? Initially, you're synchronized atrial ventricular, okay? And then you see the onset of ventricular tachycardia. We will check, of course, with the EGM, but you have a dissociation. The ventricular rate is fast inside the ventricular fibrillation area, and then dissociation with the atrium, okay? And then at the end, the patient will receive a shock. But now, if you look carefully to the EGM, what do you think? Initially, yes. So this is an exercise. You see the interval, it's nearly 100 beats per minute. So this is during exercise. And then what do you see? Here, there is a long PR interval. You agree with that?
Yes.
So during exercise, that can be symptomatic. There are a few patients with these versions of the MVP that were symptomatic during exercise because of long PR interval. And some physicians said, okay, I'm not very happy with this algorithm because of this problem, okay? It means that with the old version, there is no switch for long PR interval. Whatever the PR interval, if it is very long, but if there is one VS in between each of the atrial pacing or atrial sensing, then it will not switch to DDD, okay?
Yes, okay.
So, and that can be symptomatic. You know, at this time, the ventricular activation and contraction and the atrial one are nearly spontaneous. This is something which is called the pacemaker syndrome. You will have contraction of the atrium when the mitral valve are closed, and that can be symptomatic, okay? But what happens there, here, on this bit?
There is it doesn't sense the ventricle.
Yes.
The ventricle.
Well, you don't see the EGM here because you know that's a programming specific in Medtronic. That's sometimes a limitation of these devices, but you do not see the very first EGM. You see, you only see the markers. You see from there the EGM, but at the initiation of the arrhythmia, nominally you will not see the EGM, and that can be a limitation sometimes. But what it seems is that there is a block atrial pacing. You agree with that?
Yes.
No power wave at this time. So what happens here? If there is one blocked, then you will have AP-VP with the short AV interval of 80 milliseconds, okay?
Yes.
Because here the device is working with AAI-DDD, MVP. So blocked atrial pacing, short AV interval, and then a PVC. And then what happens? You see here, that's the atrial signal.
Yes.
That's the ventricular signal. You agree with, you have many more ventricular signals than atrial signals. So that's a real VT.
Yes.
So what you can consider maybe is that this is an initiation of a ventricular tachycardia, and maybe that part of the explanation is in the fact that with this algorithm, you can have a blocked P wave, so a pause, so a long cycle, and then a short one on a PVC, and then initiation of the VT, okay?
Okay.
And this has been described inside the literature. There have been some cases of induction of ventricular arrhythmia because maybe of the pause generated by this algorithm. That's clear?
Yeah. Okay. I see.
Okay. So here in this tracing, you can see the two main limitations of the old MVP. For some physician, that was a problem that you could not switch because of long PR interval. You could not program it. You could not ask the device to switch if there is a long PR interval. It's different, for example, in Biotronic or in microport devices, where you can ask the device to switch from AAI to DDD in case of long PR interval. And second, with this, you can have some pause, and you know that, that's of course more important during exercise. The pause can induce the occurrence of ventricular tachycardia. In this patient demonstrated 3 episodes of ventricular tachycardia, and every time that was the same phenomenon. Every time that was following a blocked atrial pacing, okay? So from these observations, something that you need to know also is that in Medtronic devices, there is no systematic recording of the switch from AAI to DDD. You do not systematically record an EGM. That's different, for example, in Boston with the rhythmic algorithm, when every time you will switch from AAI to DDD, you will record an EGM. That's not the case in Medtronic devices. So there is not a lot of tracing with MVP, of course, because it is not recorded. But since there are so many devices, Medtronic devices implanted all over the world, there was some recording of arrhythmia like this by ICDs, and you could see the VT. And then when you were looking at the initiation, you could understand that maybe the MVP algorithm was the cause of the induction of the arrhythmia. Okay, that's clear. So from this, the idea was, okay, the device has been modified, the algorithm. So if you summarize, you see here, APVS, long period interval, block AP, short AV delay, and then acceleration into the VF zone. So I will show you how to program it, but there is now a new version of the MVP. So if you implant today a Medtronic dual chamber pacemaker, then it will work with the new version of the MVP. And the idea was to correct these two limitations. You see here, the patient with a long PR interval. You see, it's 350 milliseconds, 350, 350. Programming successful. I will show you how to do it. But I have programmed now the possibility of the algorithm to automatically switch if there is a long PR interval. For example, in this patient, I have programmed a value of 350 milliseconds. And if the PR is more or at the level of 350, it will automatically switch to DDD. And that's the case here. You see here, long PR interval, and then here, it will switch automatically to DDD because of this long PR interval. So that's now a possibility. It's when you program the MVP today, I will show you how, but nominally, this capacity to switch because of a long PR interval, nominally it's off, but you can program it on, and I will show you how to do it. So that's the first point that has been modified. There is, see here, limit set at 350 milliseconds and switch to DDD. There is a second point that has been modified. The two limitations, as I explained before, was the fact that you could not switch for long PR interval on the old one. The other limitation was the occurrence sometimes of pause. When you go, I have a lot of discussion with physicians from United States, for example, and they consider that if you implant a pacemaker, you cannot tolerate any pause because sometimes the pause will be the cause of induction of an arrhythmia. So the idea in the new version was to decrease the duration of the pause. So if you look here at this tracing, you see here a patient ASVS, ASVS, ASVS. And then you have a P wave here, AS, correctly detected. But if you look, you see, after a certain duration, there are no R wave, no VS. So how does it work now? Once you have detected a natural signal, so AS or AP, there is a window. So anytime it will measure the PR interval, and then it will open a window, you know, from here to there is a window. So you wait, and then opens the window for the R wave. And if there is no R wave, then it will change the way it works compared to before. On the previous one, if there is no R wave, if there was no R wave on the old Medtronic devices, the P wave was blocked. Now, what it will do, it will pace. If I'm waiting for the R wave, no R wave, no R wave. At the end of the window, it will pace the atrium earlier than it should be. And then it will pace the ventricle with an AV delay of 18 milliseconds, the same AV delay of this AV delay of short AV delay of 18 milliseconds is somewhere the signature feature of the MVP algorithm. So in the new one, you will still see this short AV delay of 80 milliseconds. But the main difference now is that it will not wait that the P wave is blocked. If after a certain duration, the minimal value between AS and AP is 420 milliseconds. At minimum, it would wait for 420 milliseconds. At maximum, it will wait for 600 milliseconds. There are some details of the algorithm which are not important, but what you need to remember is that at minimum, it will wait for 420 milliseconds. If there is no R wave, then it will pace the atrium and the ventricle with a short AV delay. So you see here, it's one blocked P wave. It's the same, then you need to have 2 out of 4. If there is no 2 out of 4, it will remain in AAI, and that's the case. Is this clear? So if I summarize, you see here, AS, he will wait, open the window, nothing. After 420 milliseconds, he pays the atrium, then short AV delay, 80 milliseconds. This one is conducted. There is a R wave. This one, he waits, no R wave. So the same, AP, 420 milliseconds, 80 milliseconds. And then this one is considered as block. This one is not. This one is not. This one is considered as block. So it's 2 out of 4. So it will switch to DDD. Okay. So here, the details are not very important. What you need to remember, he waits at least for 420 milliseconds, not to pace in the vulnerable period of the atrium, and maybe you could induce atrial fibrillation. So you need to wait, and then the short AV delay. So you pace first the atrium and then the ventricle to respect the atrioventricular synchronization. Okay, but the advantage of this is that now that the pause has been considerably reduced, the duration of the pause, and maybe with that, the risk of induction of ventricular tachycardia will be reduced. Are there any questions?
Just does it, the PR interval, does it adapt upon exertion? Or
yes, it is.
This delay of 4.
If you consider the first version about MVP, there was nothing to do about PR interval. Now, the PR interval is monitored on every beat and is average on every beat. There is an average on the PR interval. And this PR interval will make the duration of the next window for analysis and for check for the R wave, the presence of the R wave. Is this clear? So from exercise, if you have a shortening of the PR interval, then the window will be shorter. If you have a lengthening of the PR interval, it will be longer. Okay?
But how do we set the exact interval? Like
not set it.
Okay.
It's the value are 420 milliseconds minimum and maximum 600 milliseconds. But it will average, the device will measure every time on every beat the PR interval and will average and to know how at one time will end the window of analysis.
Okay, thank you.
Just a tracing very shortly, I will show you this, but this is a patient with MVP here. APVS, APVS, APVS. Here I have changed one of the parameters. I have decreased the amplitude of the atrial pacing to be below the thresholds. So here atrial pacing is working properly, sinus dysfunction, so there is a conduction and VS, VS, VS. What I show here is that if I decrease the amplitude, then you are not capturing anymore the atrium. But if you're not capturing anymore, then there's not going to be any VS. If there is no VS, then you will have the switch to DDD. You understand? No conducted VS for the device. It will say, okay, there is now an AV block, and then I will switch to DDD. What I show here is that for this algorithm to work properly, you need to be efficient at the level of the atrium. If you pace the atrium, because if there is no capture of the atrium, there will not going to be any spontaneous activation of the level of the ventricle. I'll show you another tracing, which is the same ID. Here now, what I have altered is the quality of sensing. You see here, you sense correctly the VS. So, and on this bit, there is ventricular undersensing. You see here, there is no marker. So if there is no marker, then you will have APVP. I showed these two examples to explain that if a patient has a sinus dysfunction and a problem of atrial capture or a problem of ventricular undersensing, then you will have many episodes of switch from AAI to DDD. And if you interrogate a device, you can see now, you will not see any AGM of switching from AAI to DDD in Medtronic devices since they are not recorded, but you can go on the log, I will show you where, and then you can see now the number of switch from AAI to DDD. So if in a patient with sinus dysfunction and you know that there is no AV block, obvious AV block, but you see many episodes from AI to DD. What you can suspect is that maybe it's a problem of loss of capture of the level of the atrium or a problem of ventricular descending. Okay, so when I interrogate a Medtronic device, if I see many episodes of switch from AA to DDD, one of the possibilities is that there is a problem of atrial capture or ventricular descending. Is this clear for everybody? Yes? If you come back now to the screen of the programmer, okay, so this is a new device. So this is the new version of the MVP. The mode is written the same AAI DDD. You cannot, the second point, the fact that you reduce the duration of the pause and you will precede atrial pacing and ventricular pacing with 420 milliseconds, you cannot modify it. You cannot deprogram or reprogram. There is one thing that you can program, and you need to click on the AV intervals. You see, if you click on paste AV or on sense AV, click on it, then what you will see now is maximum AV interval limit. Nominally, as I explained, it's off. This is where you can program or not the fact that the device will switch from AAI to DDD if there is a long PR interval. So that's not obvious. It's not on the mode, it's on the AV interval. So this particularity of the algorithm, the capacity to switch in case of long PR interval in a patient program with AAI DDD, you can find it there. So it's in AV intervals, and then you will program the value. If you program, for example, 300 milliseconds, if the PR interval is, there is no differentiation between atrial pacing and atrial sensing or between rest and exercise. It's just a value, 300 milliseconds, for example. If you program it like that, if the PR interval is more, the mean PR interval is more than 300 milliseconds, then the device will automatically switch from AI to DD. Any question on that? I think that's important that you know the details about this, because really when you try to differentiate the devices from a company to the other one, that's something which is very different from one company to the other one. The rhythmic, for example, in Boston, works completely differently than the MVP or I don't know, the AI safer in the microport. Okay, any questions?
So just the rate, as we could see just before, the rate adaptative AV is just set to,
if you click
just
it
in the paste AV menu, you could see a rate.
Click on paste AV. Okay.
The rate adaptative AV.
That's something different. The rate adaptive AV is the capacity of the AV to reduce during exercise.
Okay.
Understand? If you increase the heart rate, then you will decrease the duration of the AV delay. That's completely different.
It only works on when the ventricle is paced. So.
Yes, that's a problem of pacing. So here, it's not in a patient of this sinus dysfunction. I will not discuss too much about that. Okay?
Okay, thank you.
Okay, if you come back to the screen. So the thing is, you see, the mode is important. The question is, in a patient with sinus dysfunction, so it's nominal now, AI DDD. The question is, should I program or not the rate adaptive function, the capacity of the pacemaker to pace faster during exercise? Okay, AI DDDR. Okay, so I will, if you don't mind, I will share my screen now. So I'm sorry it's written in French, but what do you think about that? This is the interrogation of a patient with sinus node dysfunction. What do you think? The patient is symptomatic during exercise. Say, okay, I'm not feeling so well during exercise. What do you think about that? Someone?
I can try if you want.
Yes, please.
I understand what is going on, but how to say it in English?
Yeah.
The patient heart
rate program AI DDD MVP. without rate adaptive response. And what is the response here?
Yes, and this is the problem because the patient, the heart rhythm of the patient does not increase with the effort.
So if you see here at the level of the ventricle, I'm sorry, it's in French, but at the level of the ventricle, you have 100% of ventricular sensing. So that's good. That's what you want at the level of the ventricle. At the level of the atrium, you have a majority of atrial pacing. Stimulate means pacing, detected means sensed. Okay, so you have a majority of atrial pacing, which is expected in a patient with sinus node dysfunction. So atrial pacing, ventricular sensing. But the problem is that there is no acceleration at all during exercise. You see, there is clearly a chronotropic incompetency. Okay, and that can be symptomatic. So in this patient, you are programmed AAI-DDD, probably that I will reprogram to AAIR to DDDR, okay? It's clear? The thing is that you need to be cautious in this patient because in some patient with a very long time sinus node dysfunction, and this patient were slow, for example, for years and years and years, be careful when you program the rate adaptive function. In some patients, they can be symptomatic. If you accelerate this patient up to 120, 120, 130, some patients, they will say, okay, I'm not feeling so well. So of course, if it's like this, if the patient is symptomatic with clear chronotropic incompetency, I will program the rate adaptive function, but be careful that in some patients you can create symptoms. You think you will improve this patient with acceleration during exercise, but sometimes these patients are symptomatic and say, okay, I prefer not to have this function because I do not feel so well at rest or during exercise. Okay, so if you come back to the screen, the programmer. So now we will say, okay, AI-DDD, you will add this adaptive function if there is chronotropic incompetency. If not, I will not program it. The mode switch, I will let it on all the time in all the patients, since in this patient with sinus node dysfunction, they have a high risk of atrial fibrillation. So I will program systematically mode switch on, and it's nominally on. Then the rates, the lower rates, 60 beats per minute, I think it's acceptable. Usually I let it like that. Then these two rates, these two upper track and upper sensor. So the upper track, 130 beats per minute. What is, I think, very, 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 very important to understand when you interrogate and program a specific patient is to understand how he will behave during exercise. And it's important to clearly differentiate people with AV block and people with sinus node dysfunction. Of course, some people with sinus node dysfunction will experience AV block, but most of them, if we consider that you have a normal atrioventricular conduction, I think that the problematic that you can encounter during exercise are really different in patients with sinus node dysfunction and in patients with AV block. And for example, the question of the problem, we will see it when we'll discuss about exercise, but the Wenckebach phenomenon or the 2-to-1 block during exercise, a patient with sinus node dysfunction will never encounter these problems. Because if you are to have a problem of 2-to-1 block during exercise, you need to be fast at the level of the atrium, which is not the case in patients with sinus node dysfunction, and you need to have AV block, which is not the case either for patients with sinus node dysfunction. So when I program this patient with sinus node dysfunction, I'm not afraid at all about Wenckebach problem during exercise or 2-to-1 block during exercise. Is this clear? So for example, I will not program the upper tracking rate, which is the rate ASV pace during exercise, very high, because this patient will never have a situation with fast atrial sensing and ventricular pacing. Okay, is this clear? So I will let these parameters at 130 beats, but I will never program in this patient 150 or 60 because that's not what they will encounter during exercise. Okay. The other question is the upper sensor rate. So in this patient, as I said, it's for me very infrequent to program a very high upper sensor rate because, as I explained before, in this patient with sinus node dysfunction, they were slow for quite a long time in many of these patients, and you need to be careful not to create new symptomatology because you will accelerate the patient for very, very simple exercise or very limited exercise. Is this clear? Okay. So remember, if a patient is symptomatic during exercise, in a patient with AV block, I will think maybe it's 2-to-1 block, maybe it's a Wenke-Bach problem or this kind of thing. But that's not the case in patient with sinus dysfunction. In a patient with sinus node dysfunction, I will think about the adaptive pacing rate. Too fast or too slow? Do I need to program dysfunction? Or do I need to decrease the amount of acceleration during exercise that could make the symptoms? Okay. In sinus node dysfunction and exercise, I will really think about this upper sensor rate. Is this too high or too low? Okay, not the upper tracking rate. Is this clear for everybody? Yes. So now we will discuss about the other parameters. You see here the amplitude, so that's the nominal value at the implantations. If you click on it, you see here that nominally now it's adaptive. If you click on adaptive, there are three options. It can be off. If you program it on off, it means that the device will not measure the thresholds at all, automatically. Okay, so you will not add the value on the curves, and I think that's not a good idea. The two options that you have, I think, are monitor and adaptive. Monitor means that every day at 1 a.m., it will measure the atrial threshold, but without adaptation of the amplitude. If you program monitor, then you will have to program an amplitude and a duration, and then it will pace systematically with this amplitude and this duration without adaptation according to the threshold. If you program on adaptive, then it will measure the thresholds, but it will also adapt the amplitude. So what you need to know, this is one thing important in patients with sinus node dysfunction, of course, because it will be atrial paced, so for quite a long time. So that's something which is important. What you need to know is the way it works. Whatever the company, at the level of the atrium, it is always, when you do adaptation, it's always auto threshold. Medtronic, Boston, Abbott, it's always auto threshold. You do the test once, and then you do not check systematically on every bit if it works. So the margin has to be quite important. So the way it works here is 3.5, but the amplitude safety margin is 2, and you will also need to program a minimal value. When we will, next week, we will discuss about patients with AV block, and then I will discuss about how it works at the level of the ventricle. In patients, of course, with AV block, it is very important to know how works this algorithm inside the ventricle. For patients with sinus dysfunction, we will just discuss about what happens inside the right atria. I'm not really convinced about these, whatever the company, adaptive programming inside the atrium, but because I don't think in terms of safety, it helps a lot. And I don't think either that it will decrease considerably the consumption of the battery. But you can program it, that's not a problem, but you have the choice, I think, between monitor and adaptive. It's very important, I think, in the ventricle, much less inside for the atrium, okay? Something which is important also, if you click on additional parameters, you see, nominally it's 120 days. It means that if you have program adaptive, it will do the measurements during during 120 days from the implantation, but without adaptation. Even if you have program adaptive, it will wait up to 120 days then to start the adaptation, because you know that when you implant the lead, sometimes there are a few marked changes inside the threshold, And if there are changes in threshold, then the auto threshold can be a problem. So the device will wait for 120 days. I know that in some centers like this, you can decrease this duration to 60 days or 30 days. I know that some physicians, when they program adaptive, they will decrease this duration at 1 month or 2 months. Okay, this clear? So remember, for Medtronic, whatever at the level of the atrium or the ventricle is going to be auto threshold without verification cycle by cycle of the efficacy of the capture at the level of the atrium and the ventricle. Something which is very important. So I will program the polarity in this patient, but something that you need to know is the way works the sensing. You know that in some company, you have the possibility to select if you want fixed sensing, like traditional pacemaker, or adaptive sensing, like in an ICD. You see, for example, in St. Jude, in Boston, you can select if you want a fixed sensing or adaptive. Here in Medtronic, what you need to know is that when you will do the configuration of the polarity, it will decide at the end if it's going to be adaptive or fixed. What I mean is that if you program bipolar sensing, that it will work like an ICD. If you program bipolar sensing, then it will work like an ICD with adaptive sensing. If you program unipolar sensing, then it will work like a traditional pacemaker with fixed sensing all along the cycle. Is this clear for everybody? So you cannot really select the way it will sense, but if you select the polarity, then you select the way it will sense. That's clear? Bipolar, systematically, it's going to be like a defibrillator for the pacemakers. Okay, that's clear? So, okay. So as I said, I'm not a big fan of the adaptive inside the atrium, but in the sensing, for the sensing, I systematically program bipolar, and it means that it will work like an ICD. Other parameter that will change if you click on PVARP. PVARP, nominally, it's auto. And you need to know something. When you program a PVARP, you want two things. The first one is that you want to have the PVARP longer than the VA interval, the retrograde conduction, to avoid the occurrence of the PMT. So the PVARP has been developed inside a pacemaker to decrease the risk of PMT. So what you want is to have a PVARP longer than the retrograde time conduction. But if you program a very long PVARP, then you may have in some patients a problem of 2-to-1 block during exercise. But as I have explained before, in patients with sinus non-dysfunction, you'll never have a problem of 2-to-1 block during exercise, except, of course, if at one time you present with AV block. But in most of the patients, you will never encounter a situation of 2-to-1 block in patients with sinus non-dysfunction, because if you, for having a 2-to-1 block, you need to be very fast at the level of the atrium, and you need to have also AV block. These two configurations are not frequent, at least in patients with sinus non-dysfunction. Okay, so when I program the PVARP in patients with sinus non-dysfunction, usually I program quite long PVARP and fixed PVARP to avoid completely the risk of PMT. You know that in patients with sinus non-dysfunction, most of them will have a retrograde conduction. Something like 80% of the patients with sinus non-dysfunction may have retrograde conduction. So I will program a quite long and fixed PVARP to avoid this risk of PMT, since I know that in this patient, I will never have the problem of 2-to-1 block during exercise. Okay, so I will deprogram the auto. If you click on it, okay, not a problem. I will deprogram the auto to off, and I will program a fixed value. Okay, just the fixed value to, let's say, something 300 or 320 milliseconds or something like that. Quite long to avoid completely the risk of 2-to-1 block. So if you close it, something that we will discuss next time systematically also, if you click on blanking, we'll discuss about it next time, but systematically I will change the partial here the p-value partial, if you click on it, to partial plus or absolute. We will discuss this next time. Okay, close. Okay. Okay. Additional features, systematically also, I will program the PMT intervention. So it will be on nominally on the next devices, but on the one that you implant now, it is still off. So this PMT intervention, I will systematically program it on because once more, there is a risk of PMT in patients with sinus node dysfunction. Okay, okay, close. And then for the remote monitoring, if you click on it, nominally, the only parameters that, the only alerts that are programmed are the integrity alerts, I would say technical alerts. It means low battery or problem of impedance. But for example, nominally, it's off for the alert according about a problem of atrial fibrillation, for example. So this one, I will systematically program it on. If I follow the patient with remote monitoring, then I will program the alert. I think, of course, you need to adapt patient by patient, but I think I will program systematically the atrial fibrillation. Okay. There is another alert that usually we do not program, but that you could program for patients with sinus dysfunction is the cumulative right ventricular pacing. If it is more than 40%, then you can receive an alert. It's off nominally. Usually, I do not program it on. It's always a balance between the interest of the information and the amount of work for all the team that is in charge about remote monitoring. So most of the time, I do not program it on. Okay, if you close it. I think that's what I want to say. So if I summarize, patient with sinus dysfunction, nominally it's MVP. My question will be, should I or should I not program the rate adaptive pacing? If there is a chronotropic incompetency, I will program it on, but be careful that in some patients, you can create some symptoms. I think I will not program the upper tracking rate very high in this patient with sinus dysfunction. I will try to correctly program the upper sensor rate. Then in terms of amplitudes for atrial pacing, I'm not a big fan about adaptive in this situation, but why not? I will at minimal program it to monitor, to have systematic measurements every day of the threshold at the level of the atrium. Okay, close, okay. For the sensing, I will program systematically bipolar sensing. And I know that if I program bipolar sensing at the level of the atrium and the ventricle, it will work like an ICD. So it's going to be adaptive sensing. Okay. What I changed systematically.
And when you say like an ICD pair, you mean that in the beginning, it's not very sensitive. And then during the cycle, it becomes more and more sensitive, right?
It's adaptive. Yeah. I will show, yeah. You see, you start first not being too sensitive, not to sense the T wave, for example, to have T wave over sensing, and then you become to be more and more and more sensitive to be in capacity of detecting slow signals like in ventricular fibrillation, for example. Okay, and then the PVARP, I will not program it auto in a patient with sinus node dysfunction. I will program a value quite long to avoid completely the risk of PMT without creating problem of 2-to-1 block, since there's not going to be any problem of 2-to-1 block in this patient with sinus node dysfunction. The blanking, I program it partial plus, and then the only thing I will program systematically the PMT intervention on, and then I will modify the alerts for the remote monitoring.